dermatology departments. I'm the ex-head of the laser department in the dermatology department in King Saud University in Riyadh. I got my fellowship from Canada in laser and also in hair transplant. Today I'm going to present something that probably all of us we are doing that is not related to my subspecialty, but I found it very interesting because something that I realized that some of our colleagues they are not doing it, or at least because it's so simple and easy to do, and you can make your patient very delighted from being like a bit sad to be happy by something that you can do it very easily, very safely, and very simply. One of the things that we are not doing it is we are not marketing like it's a scientific marketing. We're not helping our patients to recognize or to realize that this type of treatments is very helpful. It is about botulinum toxin in migraine. Because patients, they don't come to us, but just get a chance. Once you know that your patient has a migraine, you can offer them this type of treatments. So migraine, just very fastly, it's a common, see, it's 15% of your patient, they might have migraine. It's very common. Like myself, I have a migraine. I notice many of our patients, they do have migraine, and we are not helping them by something that we do with everyday practice. Pathophysiology, that probably we are not necessarily deeply interested in because that's dermatologists. But anyway, it's a disturbance of sensory processing of the impulses came from the vascular and from the muscles. It can be, by the way, just very simply, just they divided, the neurologist divided in chronic and episodic. If it's chronic, they said it's 15 days per month for 3 months. This means, what does it mean, chronic? And it has to have these migraine characteristic, like unilateral, eye pain, nausea, and so on and so forth. Probably this is the place to just go in details of migraine. If it's not so common, like in that patient, it's called episodic. What's the reason they divided into chronic and episodic? Because this disease is can be covered by insurance. Like we need to treat them with Botox. So if the patient fit in a chronic subtype, he are eligible to be treated by Botox, like in those countries who are covered by insurance. If it's episodic, they think it doesn't need it because it's less severe. Refractory migraine that's not responding to any treatment. Anyway, there's an approval, FDA approval for Botox. How it works, it's through these calcitonin-related peptide and substance B, glutamate and acetylcholine. This will be decreased. So as a consequences, there will be decrease in the inflammatory response and also decrease in the expression of semen gel receptors. So the neurologist has put a guideline when the patient is eligible for botulinum toxins. They said if he failed 2 or 3, like 1 is not enough for them to be included, and they meant mainly actually because of insurance coverage. Otherwise, if patient will respond to Botox, why he should go, for example, and he can find that a good treatment, safe and long-lasting, why he should from the first place to a medicine that probably not necessarily not helpful. So, or if there's an overuse of medication. So responder, what the definition of a responder? Those people who decrease in the migraine by 50%, and 50% they can't responder. If 30% is acceptable for certain patients who are not responding to the treatment. So 50% you can consider they are responding, even sometimes 30%. Quality of life, decreased pain and decreased attacks is what they meant by. Now let's go for the trends. What's the trend? What's the classical techniques in doing the Botox? It's very simple. I just want to just go over all what's the muscle we are targeting. Because we are, as dermatologists, probably are not familiar with these muscles that we are not using commonly. I'll just noted 7 muscles. This is the one of them is corrugator, pulling the forehead downwards. This corrugator and posterior. Posterior that we are doing all the targeting in our Botox for forehead rejuvenation and decreasing, and frontalis. So there are three muscles: corrugator, procerus, and frontalis. The other three muscles: temporalis, occipitalis, trapezius, and there's a group of muscles around the spinal cord. They call it paraspinal muscle group. So there are 7 muscles. We're going to go over them in a while. Frontalis, corrugator, procerus in the middle. I'll just come to it in a while. Temporalis, occipitalis, trapezius, which is a triangular muscle, and paraspinal muscle. So if we go to the technique, the standard technique, which is based on a study, they called phase 3 research evaluating migraine. Which is phase 3 research, these 2 letters, evaluating migraine prophylaxis therapy. What they do, they use up to 155 units, and they can reach up to almost 200 units per patient per session. Those patients, these units will be divided in 31 points of injections. Each point of injection has 5 units. Let's go over them. Let's see this one. In frontalis, we give in each side 2 spots, 2 units, injections points. In the procerus, 1, corrugators, 1 on each. So the total here is 7. Let's come to temporalis. 4 points, just divided on the surface area of temporalis. Although temporalis still are extending forwards and a little bit backwards, depends on the patient. This is the occipitalis, 3 points, trapezius, 3 points, and paraspinal group of muscle. So as a total here, like both sides, we'll find out it is at 31 sites. If patient being given these sites, according to that study, what will happen? Within 7 days, like exactly what we see patients when we are treating for facial expression, within 7 days, patient will notice some improvement. Unfortunately, some patients, they need more than 1 cycle of treatments for them to see an improvement. You need to know that because you have to tell your patients that sometimes you have to do 2 cycles, 3 months in apart. Okay? And sometimes when it's difficult, sometimes 3 cycles. But normally couple sides might be doing the good job. Careful about unrealistic patients. Patient, he might think that he'll be completely off the treatments, of the medicine. No, you have to discuss that with him carefully because if he got to pay the money, he has to know what's the benefit. And I did also pilot study. I'm going to discuss it with you at the end of this presentation. So careful about unrealistic patients. He needs completely cure the disease. Or he think that this medication will pay this amount of money, he will get rid of, he will be cured. He will come to you after 3 months. He said, the headache come back again to me. And if you don't tell him, that might be point for discussion. You have to know that repeating injections might be every 3 months, 4 months, or 6 months, depends on the severity and response of the treatment. Now let's go for the second technique that we have modified in our pilot study. We have 10 patients, pilot study. The previous technique, which is the PRIM technique, is advanced or just developed by neurologists in that trial. This modified technique, we have modified as dermatologists for our patients, and we have tested in 10 patients. The dose almost the same, between 160 to 190. These 160 is not 190. These 160 will be divided in 60 points instead of 30 points. And instead of giving 5 units, we give 2 units per injection site. Let's say that we'll compare now between the formal technique and our technique. Because we are using the Botox for usually for frontalis expression, for wrinkles. So we are expert in the forehead more than others. So we have more experience in the forehead Botox injection. So we give actually, instead of only 7, we give almost 20 points, like multiple small points with lower dosage. We give 2 to 2.5 per one session. For Procerius, we give 1, 2, 3, 4. For corrugator, we give 2, almost the same amount, but we distribute it over larger surface area of the muscle. So this is Procerius, and this is corrugator, and this is the frontalis. So we give, instead of give only 2, we give almost 6, like we treble the injection sites. For temporalis, instead of giving 4, we are give almost like maybe 10 or to 12. So we doubling to tripling the sites of the injection site. And the idea of our study is to distribute more toxins to more muscle fibers, because there's an issue, we'll come to it in a while, why we went to this technique. Occipitalis give also more injection, trapezius and paraspinal muscles, and trapezius we give more also injection site. And also we added more, and this is also in the formal protocol, more injection site at a site that patient complain more. He said, I have more headache or more like symptoms at the temporalis or the occipitalis or so on and so forth. Or in the frontal, we give extra if it's allowed, for example, without side effect, because if we give extra in the forehead, you have to be careful about the side effect, at least cosmetic side effects. So as a total, we go for up to 60 points with almost the same amount of Botox. So this is the distribution of what we have added to the formal ones. So now this is how it looks like, because in general, as dermatologists, we need to know the landmark to the patient, because we are not exact. Some of us probably not knowing the where is exactly the muscle. This one actually is a bit lower because Procerius does not go to that point, but because of the circle is too large. So this is the corrugator, okay, and this is the Procerius. So these 2 points is for one after the others. So it's not in top of each other. Like we just go to the cross or the surface area of the corrugator, one here and one there. So this is how it looks like on the patient landmark with the hair lines. And this is where the trapezius and the paranasal muscles. And these muscles, this is what I want just to note here, the paraspinal muscles need a bit longer needle because they are a bit deeper muscles. All of the previous one, the regular Botox syringe, or the insulin syringe will be enough. But for the paraspinal muscles, probably need the 1 inch needle so it can go a bit deeper. And be careful when you are injecting deeper for not to exceed the dosage, because it might cause muscle weakness. So you'll be careful, giving only 2 units at different sites with a longer needle, so it will reach the paraspinal muscles. So, and in the formal, the trapezius, usually because it's a triangular muscle, you might go deeper even to the medial part of the shoulder to inject the trapezius if patient complaining of that. So it's simple, easy. Every one of you after this lecture, if he's not like practicing that before, he can do it immediately and he can see the result nicely. So what we noticed, like the extra benefit, we see more patient response, like from the first session, more patient responding to this modified technique. Probably, if it's true, because only 10 patients is not actually enough to draw that conclusion, probably we cover more surface area of muscle. We might expect, because we're giving smaller dose, we might think that the duration of the relief will be less. Fortunately, until now, we did not see that. Still, after 3 months, patient uh, preserve the effects of that muscle. So, distributing more toxins with lower dosage give better initial response, better like patient percentage response, like instead of 50% of patients to respond, now you get probably 70%. Same duration, and it's slightly, of course, more painful because of the, let's see, go for the third technique. Third technique developed by neurologists, what they call myofascial trigger site injection technique. So they follow, because they have know where's the trigger of that migraine, they follow that muscle, and they know that well with their patients. For example, certain patients, they have, the trigger came from the corrugators and procerus. So the doctor, the neurologist, will concentrate the toxins only to that muscles. So this is another technique. In the frontalis, only on the temporalis. Depends on the patients where he think the trigger started. He said, once there's a tension here, I will start to have headache, or once the muscle is being spasmed, I'll have migraine in the following days. So they will follow the trigger muscles, so they will inject it like this, whatever there's a trigger. The fourth technique, which it should be third, because he said, where the patient feel the pain. So you will not follow exactly what you learn from us, but you have to know the muscle anatomy, because you want to inject the muscle that's very functional and very important for patient functionality. So you'll follow that, and you'll give more injection site, up to 40 units extra on that pain site where patient will tell you. So they will follow the patient techniques. All of these are very safe. One, especially if you give a lower dose, 5 units, if it's been injected in an area that's very important functionality as a function, might give some side effect if you are not careful enough about the anatomy. So if you go to our modified by 2 units, you'll be minimize the side effects. So this is the fourth technique. You can intermingle all these techniques together. You'll do your standard or modified, and you can follow the patient's symptoms. So side effect, all of you know, bruises, some facial expression changes, and as dermatologist, if we're injecting the forehead, you'll know for sure the eyebrows will be raised as a normal reaction, because we are injecting the central forehead. So you should adjust for that. Like lower, that depends on the patient preference. Adjust the cosmetic outcome by injecting better, more Botox in the certain areas. Doses, if you are not careful enough, or injecting so deeply and lower to the muscle weakness. And this happens, those beginners who are giving higher dosage, especially for the trapezius, because trapezius is an important muscle to raise the shoulders, to move also with occipitalis, to move the scalp. If you give more dosage, patient will feel weakness when he's moving the scalp. For our dermatologists, for the forehead, most of the time, we don't have that side effect, like ptosis and others, because we have a good experience in that. Temporalis, fortunately, has no much of function except like for mastication, but we don't give higher dose. All these doses, because it's a big muscles, all the doses that we have given, it's rarely to cause weakness of the mastication. But if it happens, that means probably give higher dosage than what it should be, or the patient is so sensitive. So if the patient complaining of like a weakness of chewing or mastication, that means probably give more dosage on the temporalis muscle. So muscle weakness is an important side effect you have to be careful about. So if it happens to you, it's temporarily, but you should know, know that from where it comes. So you'll avoid it in the next session. Headache, sometimes it happens if you go deep to reach in the periosteum. So again, this is what we need. This is we mentioned before the importance of muscle weakness, and she should be very careful. Before the end, for the last session, before the end, because now we are just only 1 minute left, pain diary. It's better to ask your patient to have a pain diary. What do we mean by that? If the patient comes to you and he said, I'm not responding to your medicine, then you go in detail about the symptoms. How many times the attacks happen to you? You said, Yes, better. Maybe instead of like 4 days, I get 2 days, almost 50%. The patient sometimes they did not realize that is a response. How many times you take the medicine? I said now it's less, but it doesn't go away. So you have to explain to your patient what does it mean the response. It's not necessarily curing, it's just decreasing the symptoms. So I mean, pain diary might help you and your patient to realize. Last conclusion, migraine, you have to know the, I mean, it has to be diagnosed as a migraine, not any headache. You have to know about the anatomy, not difficult, so simple, and the different techniques, patient selection, and pain diary. Thank you very much. Any questions?